Today we've got foot and ankle, and we're joined by 4 amazing speakers. And we will be joined by Mr. Lucky J. Seelan, who is our very own chair of the Fundamentals of Orthopaedics group, and he's also a consultant of foot and ankle surgery. We will also be joined by Mr. Amit Patel and Mr. Ali Najifi, both of whom are foot and ankle fellows, and Miss Iris Kwok, who is a T&O ST8 trainee on the Royal London rotation. And let's get started. So off to start is Miss Iris Kwok on talus fractures. So I will allow you to share the screen if that's okay, Iris.
Yep.
Thank you.
Hello everyone, hope you can see this screen share. Thanks for having me to talk about talus fractures today. So let's get started. So I'm going to start off with a case. So you are the registrar on call at a major trauma centre, and you've been called to resus for an advanced trauma call. And this is a 35-year-old gentleman who's been involved in a moped versus car accident. The paramedics report that there was a large dent in the van, and the patient himself says that he put his legs out just before impact. So he's come to the ED with both legs splintered by the paramedic crew. So what are your management priorities? Now, because you are a brilliant orthopedic reg and you've done your ATLS course, you recognize that he needs to be managed according to ATLS principles, high energy injury, okay? So you do your A, B, C, D, E. He has a head to toe CT scan, which shows that everything is normal. So he's essentially just got isolated injuries to both his legs. So you get some X-rays, and this is what you've got. Right leg, left leg, you can see the markers on the screen. So you can see that he's got a tib fracture on the left side. Let's ignore that and put that aside for now. And let's just focus on his right side, his right ankle. So I'm going to start with a quick poll and going to ask you what is going on here, looking at this X-ray. Does he have an ankle fracture? Is he have an ankle fracture dislocation, or does he have a fracture of the talus? And if it is it in the neck, head, body, or lateral process? Just going to give you 20 seconds to vote. And we'll see what the results are of the poll. Okay, so half of you said talar neck fracture, some said ankle fracture dislocation, some said talar body fracture. Now, I'm guessing that some of you are probably thinking that I actually need to see another view of the X-ray because you can't make a diagnosis on just one AP film. So here you go. I'm now giving you a lateral X-ray as well. There we go. So same case, same patient. This is the attempted lateral view, and I want you to vote again this time to see if you still stick to your same answer or whether you might change what you think is going on. Again, just 20 seconds quickly. Tell me what you think. Okay, so you can see that now a few more people have decided that it's actually talar neck fracture rather than the body fracture. So the correct answer is that it's a talar neck fracture. Okay, so after our quick little introductory case just to set the scene, I'm just going to quickly talk you through a few things about the talus. Okay, first of all, the word talus comes from the word talo, which is essentially ankle in Old French. And this comes from the term taxilis, which means dice in Latin. And the reason why is because the ancient Romans used to actually use the heel bones of horses, sheep, and camels as dice to play jacks with. Another term that you keep coming across is aviatus astragalus. That astragalus is a Greek word, which again means talus. And basically in the First World War, the plane pilots used to land their planes sort of belly first and putting the feet out. So the feet were forced into this, extreme dorsiflexion in a lot of force. And so this created a fracture dislocation of the talar neck, as you see in that image. And that's essentially what the injury is. And they have huge case reports written in both the world wars for this injury. So just remember that fractures and dislocations of the talus are almost inevitably high energy injuries. A little quick bit about talar anatomy. I'm not going to go into too much detail about the anatomy of the talus, but you do need to know the basics. Okay, so it's made up of the head, the neck, and the body. You've also got, there's a little jutting out bit on the side called the lateral process. So the head is the bit that articulates with the talonavicular joint. Okay, the body is essentially the dome that you see on an AP X-ray that's part of your ankle joint. And then the undersurface of the talus is what articulates with the calcaneus. And you can see the image on the right is one that's from a top-down view looking from above, and you can see the articular cartilage of the ankle joint. So my next question to you is, how much of the talus is covered by articular cartilage? Is it 10%, 20%, 40%, 50 or 70%? Again, quick poll, quick show of hands as to what you think is the correct answer. Okay, so it seems like most people do get the idea that a lot of it is covered by articular cartilage, and the correct answer is at 70%. Okay, so it's pretty impressive. There we go. Yeah, 70% of the talus is covered by articular cartilage. The neck is the bit that's not covered by cartilage at all. And the interesting point also is that there are no muscles or tendons that attach directly to the talus at all. You do get ligaments, but not muscles as such attaching to it. So amongst fractures of the talus, fractures of the neck are by far the commonest. They account for 50% of talar fractures. You can also get lateral process fractures, and I tend to think of it as the snowboarders, the people who have their feet forced in a dorsiflexion when their feet are pronated. And these are quite often missed. You know, half of them tend to be missed initially in ED or even in fracture clinic and been put off as an ankle sprain. But when you actually do the imaging, you realize that they've actually got a fracture of the lateral process. Body fractures are less common. They tend to be associated with fractures of the neck, you know, where it's just completely comminuted and smashed up. And the head fractures are the least common because it's quite well protected by that talonavicular joint. So why are talar neck fractures so important? Now, first of all, they're very high energy injuries, as I've mentioned before. So a large proportion of them are open fractures. There's a high rate of associated injuries as a result, particularly in other parts of the foot, in the ankle itself, particularly the medial malleolus, and also in the spine, particularly the lumbar spine. And also there's a very high incidence of AVN rates, which we'll come on to later. And why does it tend to break at the neck? We think it's probably because it's the weakest area of bone. It's got the smallest cross-sectional area of bone. And also the bone there is quite porous because of all the vascular ingrowth in the blood vessels. So since we mentioned blood vessels, the next question for the poll is, what is the dominant blood supply to the talus? Is it the artery of the tarsal canal, an artery of the tarsal sinus, the deltoid branch coming up from the posterior tibial artery, or is it the dorsalis pedis? And don't worry if you don't know this, because, you know, this is sort of next level knowledge. Okay, so the results show that the deltoid branch seems to be the most popular, followed by artery of the tinosinus and tarsal canal. I think it's a bit of a guess, isn't it? I don't think most people probably know the answer to this. So just going to quickly go through. The correct answer is actually the artery of the tarsal canal. Okay, so I'm going to quickly talk you through the blood supply to the talus, because that's really, really important. It's a bit like the scaphoid of the wrist. It is something that you do need to know and learn for your, you know, future interviews and exams, and even for your clinical practice. So it comes from three main sources, the talus. Okay, it comes from the posterior tibial artery on the medial side of your ankle, the dorsalis pedis, and also on the lateral side comes from the perforating branches of your perineal artery. Now, from the posterior tibial artery, it then splits. If you see that image on the right, it splits into the deltoid artery and the artery of the tarsal canal. And the artery of the tarsal canal is actually the most important branch because it supplies 2/3 of your talar body, and it comes through that talus through little sort of sinusoids. The deltoid branch is important in that that's often the only remaining branch of artery that's left intact. So when you go and fix your talus, you don't want to injure that branch because that could then bring about AVN to the patient if you injure that last remaining branch. But do spend some time to look at the diagram and study the fact that it's almost like a sling, that the arteries come from both sides to go through the talus, and do learn that for the future. So let's go back to our case. So I put a normal ankle X-ray next to the one that we've got, okay, just to illustrate the difference. It's pretty obvious now that you've got something normal to compare it to. And you can see that there's a medial dislocation at this talar neck where everything distally has shifted medially. And this is the more common type of dislocation compared to a lateral dislocation. And if you go to the lateral X-ray, again, there's not a proper lateral X-ray, it's the best they could get in resus. But again, you can see that the neck itself is snapped into two, and the talar head isn't quite pointing in the right direction. So because you are in a trauma center, you've got immediate access to CT. So I've put here some sagittal slices of the CT scan. And so you go to your consultant and you tell them about this case. And the first thing that your consultant asks you is, what Hawkins type is this injury? Is it type 1, type 2, type 3, type 4? And some of you might be sitting there thinking, what is Hawkins? What is he on about? So a quick vote to see what you think of this injury. Looking at that sagittal slice alone, it should give you enough information to classify the type. Okay, so probably a third of you don't really know what Hawkins classification is, which, you know, is fair enough. That's the whole point of the talk. And then an equal number, say type 2 or type 3. Nobody's saying type 1, which is good. Well done. So what is Hawkins classification? So there's a type 2, first of all. That's the correct answer. It's a type 2 fracture. So this is the Hawkins classification, which is for talar neck fractures specifically. Okay, your type 1 is the completely non-displaced fracture. You just get a break in the talar neck and that's it. Type 2 is where you have a fracture in the talar neck, but you also have a dislocation of the subtalar joint. I've highlighted that bit in green just to, you know, really show you. Type 3 is where you have a fracture, but you also have a dislocation of the subtalar joint together with the main ankle joint, the tibio-talar joint. Okay, so those two green bits that I've highlighted. And your type 4 is obviously the worst type, where you have a dislocation of all three joints, the subtalar joint, the tibio-talar joint, which is an ankle joint, and also your talonavicular joint. And the reason why this is important is because this affects the AVN risk of the talus. If you look at the AVN numbers, type 1 is only 50% AVN rate. Type 2, you're already up to 50% of a risk of AVN. And your 3s and 4s, you're pretty much doomed. You know, you're up to sort of 90 to 100% AVN risk. So it's got a sort of prognostic factor to it, which is why you do want to try to classify them. Going back to our case, you can see, you know, a normal CT alongside the one that we've got. You can see that together with the talar neck fracture, that the subtalar joint is definitely gone. It's not normal, okay? So your ankle joint is still okay, your talonavicular joint is okay. So that's why this is a type 2. Okay, so back to your case. It's 10 p.m. at night, you know, you're on call. So the question is, what are you going to do now? Are you going to back slab this leg and then discharge him and then follow up in fracture clinic? Are you going to apply a back slab and then plan to fix it tomorrow on the trauma list? Would you attempt to reduce it before putting a back slab on and then plan to fix it tomorrow? Or would you try to fix it tonight on the CPOD list, you know, as an emergency, regardless of whether you can reduce the fracture or not? So again, let's do a quick poll to see what you think. Okay, I'm quite relieved by that to see that the majority of you say try to reduce it first before you cast it and then plan to fix it tomorrow. So I completely agree. That is the correct answer in this case. Because the subtalar joint is dislocated, you would really try to reduce it. And going back to your original clinical image, this is why. You can see that the area of skin and soft tissue is already blanched there. If you leave it too long dislocated, you're going to run into trouble with the soft tissue, with necrosis and it potentially even coming through the skin. So that's why you do need to urgently reduce it. Once it's reduced, you can then, wait to have it fixed when you've got the right expertise, by a foot and ankle surgeon. So in this case, the patient had an attempted reduction. Unfortunately, it didn't actually change very much. Didn't really get it reduced properly. So he went for surgery the following morning. And you can see here they've used a dual incision approach. So they've gone both sides, anteromedially and anterolaterally. I haven't gone into any detail about the approaches in this talk, but it is certainly something that's worth you reading about, certainly before you become a registrar. The anteromedial and anterolateral approaches tend to be the most common ones used for fixation of the fractures. And you can fix it with screws, plates, whatever works to achieve anatomical reduction. So he's had a really good fixation, and these are his post-op images at the bottom with some cannulated screws, and has restored the anatomy of the subtalar joint as well as the talus itself. So let's fast forward. This is now 6 weeks down the line, and you're in fracture clinic, and he comes back to you, and you assess him, and you do some check X-rays, and the consultant asks you, has he got a Hawkins sign? So you're thinking, oh gosh, what is a Hawkins sign? I thought a Hawkins classification is probably enough. So my question to you is Hawkins sign a good thing or is it a bad thing? Do you want to see a Hawkins sign in a patient? So quickly vote on that. Is it a good thing to get a Hawkins sign, or is it a good thing to not get a Hawkins sign in your check X-rays? Oh, okay. So 2/3 of you think that it's a good thing to get a Hawkins sign, and 1/3 of you think actually no, we don't want a Hawkins sign. So the correct answer is that actually a Hawkins sign is something that you do want to see on X-ray. Okay, it's actually a good prognostic sign. What a Hawkins sign essentially is that subchondrolucency that you can see in this image here, where the little arrows are pointing to, that little black rim on the talar dome. And that's something that you would expect to see probably at about 6 to 8 weeks. And what it means is that there is blood supply coming into the talus and therefore causing bone resorption. And it's the bone resorption that gives you that black appearance. Whereas on the other hand, if there's no blood supply going in and you're getting AVN and it's just a dead bone, then you see the sclerosis and you see like just a white dense piece of talus, and that's actually really bad. So if you see a Hawkins sign, it's actually a really good thing. You know that there's blood supply coming into the talar dome. So there's our patient 7 months down the line. Okay, he's still doing okay, but he finds the screws quite irritating. So he actually had his screws removed as an elective thing, just so that he doesn't get the impingement at the back of this ankle. And this is him at 2 years. All the metalwork is out. And you can see that the talus has actually gone quite white. He does have an element of AVN of the talar body. However, he's actually symptomatically doing really well. And he's quite happy with it. So despite, this partial area of AVN, he's actually functioning well. And so we didn't have to do anything with him. And he's since been discharged from follow-up. And we'll see how he does in the future. Okay. So that concludes our talk, and actually the key take-home messages I would say from me is if you remember nothing, remember that talar fractures are high energy injuries. Okay, so always look for other associated injuries with it. Relocate it urgently. If it's your Hawkins 2, 3, and 4 where you have a dislocation of one or more of the foot joints, don't wait till the morning before you try a relocation. It's not always easy to relocate them, but you should at least try, in resus if you can. Know your Hawkins classification, because that's got a prognostic element to it in terms of AVN rates. You can then counsel the patient, that this may not be the end of his problem, that he may have other procedures waiting to be done in years to come, and know your blood supply to the talus for your exams. And certainly follow them up. Don't just discharge from the fracture clinic, okay? And look for your Hawkins sign, which will give you, again, a prognostic sort of idea. All right, so that's me done. So any questions that you've got, do post them in the chat and we'll try to answer them as much as we can. And I'm going to pass myself on to Ali.